Bismillahirrahmanirrahim. In this video, I'm going to upload a lecture on melanocytic nevi and dysplastic nevi. Okay, so what is a nevi? It is a congenital lesion of the skin, and melanocytic, as the name indicates, it arises from melanocytes, and it is benign. Okay, and it can be congenital. A melanocytic something can be acquired and it can be congenital. Okay. And as they say that, strictly speaking, the term nevus denotes any congenital lesion of the skin. The melanocytic nevus, however, refers to any benign congenital or acquired neoplasm of melanocytes. Okay, so how do melanocytic nevi arise? And if they're benign, then what kind of mutation is there underlying? So they're benign neoplasms and they're caused by a somatic gain of function mutation in the BRAF and the RAS. Which are the genes that are related with the tumor suppression and stuff. Okay, so initially there is melanocytic proliferation since it's benign. So initially there's a lot of melanocytic proliferation, and that is followed by senescence. And the proliferation basically takes place along the dermo-epidermal junction. And the cells over there, they are in the form of nests, and they have a lot of melanin pigment, so they are tan brown in color. And since they are at the junction of the dermis and the epidermis, they are called as the junctional nevus. Now these cells, they start moving downwards from the dermo-epidermal junction into the deeper dermis. And as they go and migrate into the deeper dermis, they start becoming small, they lose all their pigment, and they start changing their orientation architecturally from nests to cords or single cells. So since they are just in the form of compound cells or single cells, they are called as compound nevi. And as they go further into the deeper dermis, they simply lose their architectural orientation, and they get some fusiform contours. So since they're in the deeper dermis, they're called as the intradermal nevi. But again, the good thing is that as they go into the deeper dermis, although they started proliferating, but eventually they'll end in senescence, and that is the good thing, and that is why it is called benign. And the presentation is that the person will only present with some cosmetic concern. There may be some irritation which may mimic like a melanoma, but there isn't anything to worry about. You may do a surgical excision of the melanoma, of that melanocytic nevus, just for the sake of the cosmetic concern. Okay, and the important thing is that the compound nevi and the intradermal nevi, they are a little elevated. You can see and appreciate the picture that is given in Robbins and Cotran, in which they are showing that a melanocytic nevi is basically relatively small, symmetric, and it is uniformly pigmented. And a nevus that is composed of melanocytes that lose pigmentation, and they become smaller and more dispersed as they extend into the dermis, and all signs that speak to the benign nature of the proliferation. Now let's move further into the discussion about a dysplastic nevus. So as the term dysplastic indicates, that it must be a precursor to a neoplastic lesion. So yes, a dysplastic nevus can be both sporadic and familial. And if it is familial, which means if it is a dysplastic nevus syndrome, then it can increase the risk of melanoma. And sporadic mutation again arises from the same mutations that we saw in a melanocytic nevus, which is the BRAF and a RAS mutation. So what is the morphology? Dysplastic nevus are quite abundant when they're present. So they are in hundreds, and for example, in this picture, they can see that there are numerous irregular nevi on the back of a patient with dysplastic nevus syndrome. So please follow the pictures on Robbins and Cotran. And they're comparatively larger. So they're irregular and they're larger in size, that is more than 5 millimeters. So it's basically initially a compound nevi, which is basically having abnormal growth. And what I hope you remember what a compound nevi is, that we already mentioned, that it's basically that it's in the dermis, and they're in the form of cords or single cells, or rather some little nests. So they are compound nevi initially in the dermis, and they have some abnormal growth, and they start undergoing bridging, which is basically that it's the that the adjacent nests, they start coalescing and they start getting together and they start fusing, and that's an abnormal fusion again. So that is bridging, and after bridging they go from the dermis and they start going towards the dermo-epidermal junction, and they start replacing the basal cells along the dermoepidermal junction. So in melanocytic nevus, they were actually going from the dermoepidermal junction into the deeper dermis, whereas in the dysplastic nevus, they're actually going from the dermis into the dermoepidermal junction. And since they're replacing the basal cells, and they also have some abnormal growth, so they have all the features of abnormal growth, like a hyperchromatic nuclei and all that, and some cytological atypia. And as they go into the dermoepidermal junction, this phenomenon is called as the lentiginous hypoplasia. Now our body responds to it. The host response to it is basically that you'll appreciate a sparse lymphocytic infiltrate, and sometimes, since they're irregular melanocytes, so they'll release that melanin pigment, and the body will respond to it by fibrosis. So as you see in the picture, that there are irregular dark staining nuclei, and there are characteristic parallel bands of fibrosis. So fibrosis is basically a host response to the release of melanin pigment, and the presentation is that a person will present with irregular dysplastic nevi, and for that person there is an increased risk of melanoma. But sometimes the melanomas, they arise de novo, and sometimes they can arise from an existing dysplastic nevus syndrome. So a dysplastic nevus syndrome is a precursor for a cancerous lesion.